All right, so this is exciting. How many of you attended my talk at the Med Science conference already? Okay, not too many. That's good. All right. So those of you attended, I'll still try to keep it interested. Okay. So I have a few disclosures. I do participate in clinical trials. I do advise some pharmaceutical companies. I will use several images. In fact, the primary portion of the talk will be a series of images that I'll show from my book to help go through some of the medications in Prader-Willi syndrome. And we will discuss non-FDA indicated uses. As you heard, one of the big issues right now, we have only one FDA approved medication for Prader-Willi syndrome. We also saw that the predominant burden of illness is psychiatric, right? In Prader-Willi syndrome, and there are no medicines for it. That doesn't mean that we don't have medicines. We have a ton of medicines in the world of psychiatry which are highly effective and when used in the right way can improve the lives of your loved ones with PWS. You know this already. It's rare. You know that. Okay. All right. So here's the thing. We have now. This is a very simplified schematic which I've used for years. If you've seen it before, you can close your eyes for 5 minutes. No, 2 minutes. There are a ton of features which are problematic in Prader-Willi syndrome. I highlight, of course, everyone knows about hyperphagia and aggression. And remember, I'm putting hyperphagia within behavioral features, and that's important for you to know. It is a behavior, right, which is problematic, and that is why in the FDA, the committee that looks at PWS is actually psychiatry, not endocrine, not endocrinology, not neurology, it's psychiatry. So that's important to remember. And there is a big role of impulsivity, and we'll talk a lot more about impulsivity. There is intellectual disability, looks different in PWS, as you guys know already. When your loved ones with PWS walks up to a stranger, the stranger would be surprised if you told them that they have any neurodevelopmental abnormality, right? Because they have, they have a difference between their executive functioning, right, versus their ability to express themselves. They express themselves really well, most of them. Autism is a huge overlap with Prader-Willi syndrome, and I think in previous years when I would give this talk, people would be surprised, sometimes offended that I mentioned the word autism. Not so much anymore. Most of you in the room probably know that recognizing autism and having it treated through effective means early in life improves their life for the better. Okay, so there are obsessive and compulsive symptoms, not OCD, right? So it's important for you all to be educated about this because the terms you use makes a big difference to your doctors, right? If you go to your doctors who have seen maybe one patient with PWS, and that's your child, in their career, you say OCD, they think OCD. They're not thinking, oh, there's compulsivity and obsessiveness, but it's not exactly OCD. So you can try to use words like they have compulsive behaviors or they have obsessive compulsive symptoms, not OCD. All right. ADHD is very common. So in anybody with any developmental delay, right, folks with other developmental delays, they are at a high risk of having ADHD symptoms, and that's true for Prader-Willi syndrome as well. And then there's an interesting mix between mood disorders and psychotic illness, which is called cycloid psychosis, right? Now, mood disorders can be the more commonly sort of associated. When you think about mood disorders, what do you guys think of? It's a workshop, so I'll try to engage you guys. When you think about mood disorders, what are you guys thinking of? Bipolar illness, ups and downs, right? And in most of us, we'll mostly, experience the downs, right? Depression is a lot more common than bipolar illness or mania, right? In our patients with PWS, you can also see depression, by the way, and that is why for the clinicians and for yourselves, think about whether or not there's a strong family history of depression. If your family has a strong history of depression, your child may have that increased risk, whether or not they had PWS, right? So PWS doesn't protect you from getting depressed, right? But so it often goes unrecognized. So depression should be asked about. But the more sort of alarming problem is when they have this extreme mood switching to an increased or elevated mood, inability to sleep, and other symptoms, along with psychosis, right? This combination is called cycloid psychosis. And given the time, we'll talk about that a bit too. Now this is from my phone camera, right? You guys recognize this? Where's this from? This is, yeah, when at the FDA meeting, you guys clicked, and look at that, anxiety, behavior, anxiousness. I don't even see, where's hyperphagia, guys? Where's hyperphagia? No, okay, so now the fact of the matter is, anxiety is the most common complaint. Now that's another, we want to change the way you describe. You guys are highly educated. This sort of a community does not exist, in other syndromes. So you want to educate each other, and perhaps even stop yourself from using the word anxiety, right? So anxiety is like if I have a headache, right? If I have a migraine headache, a hemicranial, left-sided migrainous, chronic migrainous headache, right? And I just called it, and I just come up to you and say, I'm in pain, right? The doctor does like, okay, the doctor will try to investigate further. But when you say anxiety, doctors again think that, okay, you have an anxiety disorder, period. That's the end of story. Oh, you have PWS, you have an anxiety disorder, let's give you Prozac, let's give you Xanax, let's give you this, that, or the other thing. So try to break it down, try to think about that in greater detail. Hopefully by the end of this talk, although we're gonna spend more time on medication, you have more words to describe what your loved one is going through, okay? Because it's not just anxiety, and that's what you all are saying. It is not just anxiety, okay? Anxiousness is perhaps a better word, and I'm glad it popped up there, because it tells you that you don't know exactly what's going on. You're not calling it an anxiety disorder, but you see a lot of anxiousness, okay? Your child is very worried about something, you don't know what. I think just try to explain, elaborate, because if you use very medical, for doctors, anxiety becomes a disorder, it's not a symptom anymore. Okay, so I'm gonna go over what you experience on a daily basis, and I'm, if I'm wrong, I want you to give me feedback so that I can improve this model, okay? I've been thinking a lot about how to describe the getting stuck aspect that patients with PWS experience, right? That all of you live through. So we have this advanced ability of flexibly adapting to dynamic environments. So how many of you, how many of you love Disney? Okay, all right, very good. So I have at the Med Science conference, it was just the day after, 2 days straight in Disney, and I hated Disney then. Okay, so I went to Hollywood, studios yesterday, and I feel a little better about it. So all right. So, but response monitoring is our ability to flexibly adapt to dynamic situations. Okay, so you had a day planned for Typhoon Lagoon, right? And then a snowstorm sets in, and then you very quickly change your plans, and now you're going to Hollywood Studios, which was your hidden plan anyway, because you wanted to go to Star Wars and Millennium Falcon. That's beautiful, right? So you were able to flexibly adapt. Your loved one with PWS, on the other hand, were like, I've been thinking about Typhoon Lagoon for the past year. How could you do this to me? How could you? How could you? How could you? Crying, putting themselves on the floor, refusing to move, and it's a disaster, right? So what's happening is that in the context of uncertainty, right, there are several things happening. There are outside stimuli, okay, thunderclaps, you know that there's something coming up and you'll have to change your plans. Or there's intrinsic stimuli. You're like, okay, your body is a danger detection machine, right? Your gut instinct, right? Your sort of clenching of your jaws, or that neck ache that refuses to go away, or that sore spot in your back. That's all telling you something, right? These are all intrinsic stimuli, your body telling you that some danger is coming up. So one of the most effective questions that I've found to be most effective is, and those of you who've seen me privately would know this, I ask the question, do you feel like you're walking on eggshells? It's completely, so out of 10, 10 being the most walking on eggshells feeling that you ever had, and 0 is none at all, where do you stand right now? That's a question that I use, like scientifically I can say that it tells me pretty well whether or not my treatment is working. And that's completely based on intrinsic stimuli, how you're feeling, how you're feeling around your loved one with PWS. So the extrinsic stimuli and the intrinsic, you take all of that information, right? And the higher functioning part of your brain sort of like corresponds or talks to the information coming from the rest of your body, right? And then you adapt to that situation. And hopefully you have a good decision where you're able to convince your loved one to go to Star Wars. But usually when this system of communication, and remember, in the middle here, the part of the brain which is most likely intimately responsible for this balancing act, right, is the hypothalamus. We all know the hypothalamus. We all know the hypothalamus. Right, okay. So we all know the hypothalamus. And unfortunately, that relaying system, that complex relaying system, which is getting all that, hormonal information from the body, and is also bringing in and sending back to the higher part of the brains to make a good plan to adapt, this whole system seems to be in trouble. And that may be responsible for what we call response perseveration. I'll talk to you more about that. Impulsivity, even aggression, right? So before you know it, a punch has been thrown. There are lots of sorries afterwards. A kind of reactive aggression, not like the Bernie Madoff cold, planned aggression, because that would need a lot of this stuff, right? It's a very sort of reactionary type of aggression. So, all right. Any questions so far? No, okay. All right. So response perseveration is basically a failure of the previous system, right? Right. So right, exactly. So response when response monitoring is not happening well, right? It is a repetition. So in this case, even if it is maladaptive, usually, even a 5-year-old, a 4-year-old, when they see the expression on your face that you're getting upset, so Mom, when am I going to see Dr. Singh? When am I going to see Dr. Singh? And they've asked you 2,000 times already, and you sort of yell back at them, right? A normal parent activity, yelling back at children, right? So like, I've said this 2,000 times, for God's sake, leave me alone. Where's your dad, right? So, right, so that sequence of events for any other child would be like, okay, let me take a step back. Mom seems upset. Okay, this is not an effort worth sort of pursuing. That aspect is also an important part of response monitoring, which is effort appraisal. Right there. Okay, is it worth my time to piss Mom off even further. And you know, and there's a failure in that, right? And despite that negative influence, despite getting sort of like all of that anger, they would keep going through that same loop because in some way they feel like that's making them feel better. And they're better at it. They're better at repeating the same task over and over rather than adapting to a new situation, right? Okay. So, right. So they're going to do that. Perhaps, you know, it's still, perhaps, you know, you take a step back and remember, try to remind yourself that this is easier for them. That's why they're doing that. Right? So how do you break that loop without, you know, feeling like, you know, you're upsetting them further? There's a question from the back. That's correct. Yeah, and I don't think we can distinguish it well, and that is why I feel like if there are enough symptoms of autism, you know, like this behavior, you want to pursue it. It's so this failure in response monitoring, or this, I wouldn't say complete failure, but this reduced ability to monitor your responses is common in many neurodevelopmental disorders. It's called many neurodevelopment. I'm just saying that it's a very key component of Prader-Willi syndrome, right? So you're right. You can't. I think just, you know, and it's not. This is I find response perseveration to describe this really well, and I think this describes it better than compulsion. But your doctors may not use the words response perseveration. So you can say. So that's why I would say. So again, is it anxiety? Is it impulsivity? Or is it response perseveration? Impulsivity is doing something without thinking, basically, right? So I think I would, it's related to compulsivity. Response perseveration comes closer to the definition. I would say my child has compulsive behaviors, right? Because they can't stop themselves from keeping on doing what they're used to, right? And they have poor frustration tolerance. Very descriptive words, very lay words, descriptive words for your doctors. That's what's going to work, right? Because they're not familiar with this. I'm just being honest, right? Okay. Right. They can do the whining, moaning. I've had patients who would engage in aggressive behaviors, not wanting to be aggressive, nonverbal or minimally verbal patients will just go for the throat, for example, right? Even for strangers, because it's just a particular trigger. Yeah, every time they're on this particular path, or every time right before entering the front door, they have to, you know, pinch their dad really, really hard. I mean, pinch like, you know, huh? It's so there's a lot of these learned behaviors, and that's where behavior therapy can become really useful, right? ABA and other forms of therapy to break that cycle. Okay, so this is basically just a simplistic. I mean, you know, this. So I'm. It's like a waterfall, right? So there are genetics involved, which is affecting the neurobiology. The center of it is the hypothalamus, right? But there are other things involved, and then it leads to behavioral manifestations. Now, this is a very complex slide. You know, I'm going to go over it one by one. This just goes over the medications. I want you to know that everything is in my book. If you want more details, please definitely go to my book, and you will be able to, you know, a lot of my patients, providers like psychiatrists and primary care providers have found it useful also. So, so now I'm going straight into medication, right? So, and if I'm jumping some steps, please stop me and ask me questions, okay? So for irritability and aggression, right? Very common symptoms, right? It could be episodic or chronic, right? So the drawing a timeline for your loved ones with PWS along with your provider is going to be very important, right? It's one thing if your loved one with PWS is always upset about not being able to sort of watch their favorite show 10 times a day, right? And that's always been the case. That's chronic, right? And they throw a tantrum every time they don't get to see that show. Okay, you've known it, you expect it, you get upset about it, but it's chronic. Episodic is when there's something that's coming completely out of the blue, never happened before, right? And you're not used to it. Where's this coming from? That's episodic. And if there is, so let's deal with chronic first, right? Usually, chronic issues are coming with features of ADHD. Okay. Now, ADHD is very misunderstood, extremely common. It is the most common psychiatric disorder of childhood. Okay? It's okay, okay. So the question was, if parents have ADHD, what are the chances of the child to have ADHD? Extremely high. ADHD is the most heritable, even more heritable than bipolar disorder. So ADHD is the most heritable, followed by bipolar disorder and depression, and then schizophrenia. So you can imagine, my my patients with ADHD, with or without PWS, the parents, very often I have to ask them to go for their own treatment because they're always missing appointments and things like that. So 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 so, you got to be, yeah, but it is very common, yeah. Okay, we'll come to psychosis. Yeah, yeah. We'll talk more about psychosis. And there's a break after this, so hopefully we'll extend by 5 minutes or so. The all right. Now ADHD. ADHD is misunderstood not just because it's ADHD and it's controversial in non-scientific circles. Attention deficit hyperactivity disorder misses the key part of the three umbrella items that fall within ADHD. It's inattention, hyperactivity, but it's also impulsivity. Impulsivity is a big one, right? Doing things without thinking about it before. And if there are ADHD symptoms, and folks with PWS are often not, people don't pick up the ADHD because they're not very hyperactive. They have low muscle tone. They're not really moving around too much. They have excessive daytime sleepiness. They might have other sleep disorders that is keeping them from being as hyperactive as other folks with ADHD. So if the ADHD symptoms are not that, I think there's another part to it. If the ADHD symptoms are there, right, then why did I say no here? There's an error here. Okay, if the ADHD symptoms are there, right, then you can give them an alpha-2 agonist. So alpha-2 agonist is medicines like clonidine and guanfacine. Now guanfacine is something that I've done. The first patient I ever saw, I used guanfacine on, I published on it, and that's become my research. We have some new data, and I'll talk about it also. It seems to be the best option if there are chronic issues of irritability and aggression with or without ADHD symptoms, right? Alpha-2 agonists, right? So that would be things like guanfacine and clonidine. If it's episodic, right, you need to really think about psychosis, right? Same things if there are obsessive compulsive symptoms, right? Is there any mania, hypomania, or psychosis, right? And we'll talk about psychosis like I mentioned before. If there is psychosis or mania, if these things are going on, you need to treat that first. That's it. It becomes, it trumps everything else. The second psychosis comes into the picture, then nothing else matters. You just need to treat them very aggressively and right away. And then you use antipsychotics and mood stabilizers. Antipsychotics are medicines like risperidone. How many of you have heard of risperidone? Right, very commonly prescribed medicine. And risperidone is perhaps the most studied amongst all of these medicines, and perhaps safer than others. There are other medicines like Zyprexa or olanzapine. How many of you have heard of that? Okay, so that's a medicine which is very effective but can cause a lot of weight gain, right? How many of you have heard of quetiapine, Seroquel? Okay, can cause a lot of weight gain, all right? So effective but causes a lot of weight gain. So you have to think about which ones to avoid, which ones to go for. Aripiprazole, Abilify, how many of you heard of that? Okay, relatively weight neutral, okay? Um, Lurasidone, Latuda, how many of you have heard of that? Okay, relatively weight neutral. Okay, so talk to your doctors about what would be best for your child. All of these medicines are effective, but what would you want your child to take long term? These are not medicines you take for 2 days, right? If there is psychosis, you're going to have to take this medicine for many years, perhaps even lifelong. There's a question from the back. Escitalopram or Lexapro. The question is about escitalopram or Lexapro. That's an antidepressant type of medicine. Okay, so Prozac or fluoxetine, right? Heard that. Zoloft, Sertraline, escitalopram or Lexapro or Celexa, citalopram. These are commonly used medicines. These are actually the most commonly used medicines, right? And they're the first go-to. Because what will happen, you go to a doctor's office and you say, my child has anxiety. You bypass all of this stuff. And I'm only on the first thing, right? You bypass all of this stuff, you say, my child has anxiety, and they go on an antidepressant immediately, because these are the most commonly prescribed medicines, even by primary care providers. Question from the back. So usually doctors would wait. So when the problems show up in school age, right? Because before school, you're used to it, and you're not like and they're getting one-on-one attention. Things are easier. There aren't too many strangers involved. Usually around 6 years of age is when you'll see. But I have patients as young as 4. Sometimes even younger, or people just come in just to get a sense of what might come up in the future. But usually 4 is when people actually start thinking about treating with medication. 6 is a lot more common. And then it kind of goes up as people get older. Right. Yes, it is. But then see, the Invega is paliperidone, right? It's a sister drug of risperidone, commonly used. Um, so a long-acting injectable, right? A lot of these types of medicines come in once a month or twice a month or even once every 3 months type of medications, and that's mostly targeted for people who refuse to take medicines, right? So there's a strong compliance issue. I have like there it's that's rare in Prader-Willi syndrome. Folks with PWS usually, especially if they see a benefit to the medicine or they feel somehow supported through the medicine, they actually want to take medicine, and they're used to taking so much more that there may be a couple of patients who are like very sick in group homes that I've had to give it for, right? Right, I'll come to Vyvanse. Yeah. Okay, good. All right. So the amongst the antidepressants, the medicine that has been studied quite a bit more recently by my colleagues, our colleagues in Germany, is sertraline. And because I was the problem with using antidepressants, and which is why one of the reasons why I want you to elaborate to your doctors what you mean by anxiety, is that antidepressant, remember they're antidepressants. Even if you're giving them for anxiety, they are trying to do the opposite of having the mood of depression, which means that they might switch you over to mania or hypomania or psychosis. And that has happened to many of the patients who come to me urgently because they went to the primary care. The primary care started them on something at a low dose, which worked great, so they wanted more of it. They got too much of it. All of a sudden, they're ending up totally psychotic. And there might be some reasons behind that, and we'll discuss that. But the fact of the matter is that sertraline at very low dosages, so when you or I get super anxious or have panic attacks or depression, we are given Zoloft, right, or sertraline. We are starting at 50 milligrams, 200 milligrams. Folks with OCD are on 300, 400 milligrams of sertraline, right? Which can be harmful to folks with PWS. So in PWS, we're talking about 12.5 milligrams, 25 milligrams, really, really low dosages. Okay. Right, right. So the mood stabilizers are of two types of moods, two major types of mood stabilizers. There's lithium, and then there are anticonvulsant type of mood stabilizers. Right. All of these medicines work by changing the permeability of the neurons. Right. So it kind of help to balance out the sort of what's inside of the neuron and what's outside of the neuron, right? So long story short, there is evidence for lithium, right, and medicines like valproic acid or Depakote, right, and I'm using brand names just because it's familiar to you all, and then things like I think a common one in PWS that because of some research that was done many years ago, trileptal is pretty commonly oxcarbazepine, and Tegretol, which is carbazepine. These are carbamazepine. These are medicines that are prescribed. Each one has risks and benefits. Because when I see folks with cycloid psychosis, and that's the only reason for me to consider this class of medicine. That's the predominant reason. I usually go for an antipsychotic because antipsychotics usually have good mood stabilizing properties. Lithium, in particular, has been shown to be pretty helpful also. So lithium is very commonly prescribed in PWS, especially in the older patients. There's another question on this side. Okay, so there are a lot of differences. I think I have a slide on that. I'll come to that in a second. If I forget, please remind me. Okay, so ADHD. Now, I'll talk about ADHD with excessive daytime sleepiness and without excessive daytime sleepiness, right? If there's no sleepiness, or the sleepiness is not too bad, all right, I guess the slides are taking me to another path. So if the child or the adult with PW, if the person with PWS has excessive daytime sleepiness, then the question to ask is there significant skin picking or tics? Now tics, how many of your loved ones have tics like eye blinking and right? It's not as rare as people thought, right? And I haven't seen anything in the literature yet about tics in PWS, but I think there's something there that we're missing. Okay, so if there are no tics and skin picking is not too bad, then a stimulant is really can be a really safe option. So medicines like Vyvanse that were mentioned before, so there are two major types of stimulants, methylphenidate type of stimulants, right, and amphetamine type of stimulants, right? Now these can sound scary because they evoke sort of images of crystal meth, but it's not the same thing. It's it's not the same thing. You're not like, if you take like a bag full of Vyvanse, you pound it down and do something with it and snort it straight, then God help you. But that's not what our patients are doing, okay? So these are tiny dosages, right? And they have a deficit which it's filling. So if you or I took amphetamines or methylphenidates, then we are at risk of getting addicted to it. But folks who have ADHD actually tend to have lower risk of addiction, even to other substances, if their ADHD is treated. Okay, so they're pretty safe. So Vyvanse is a prototypical example of a long-acting amphetamine derivative. And Concerta is another one that you might have heard of. That's like a long-acting form of a methylphenidate derivative. And then there are short-acting forms like Adderall and Ritalin, right? They all work very similarly. They're very effective, gold standard type of medicines for ADHD. Okay, And one shouldn't feel shy about it, especially in the younger kids. It can be very helpful with sort of gaining education, paying attention in class. If they have very severe tics or very significant skin picking, I've seen that they might get those things might get worse.
So I have a son with Prader-Willi syndrome, and he, more recently, more recently, he has been obsessed and focused on his toenails, but specifically, if his toenails, when his toenails are clipped, if there are parts of the toenail that's missed, or if there's what he thinks is a hangnail, he won't let go of it. He won't.
Yeah.
I mean, he won't get, oh, I don't mean literally that, and holding onto it. What I mean is, he won't let go of the thought of it, and he won't move on.
Yeah.
So is that, where does that fit in?
Right, right. So just for everyone to kind of relate to this. So, how many of you have loved ones who kind of get stuck on, a hangnail or something stuck under they feel, there you go. So, sir, you're not alone. Yeah, just so you know. Yeah. So I have patients who will go through boxes of band-aids a day. I have patients who've pulled out their toenails multiple times. I've patients who've dug into their, like, under their teeth. But and then of course there's rectal picking. I think there's a common factor there. I think there are two things. One is that compulsive type behavior, response, perseveration. I got to keep doing what I'm doing because I'm good at it, and no one can stop me. And then there's the other aspect of, they really have poor pain threshold. So there is one of the genes which are not functioning in folks with Prader-Willi syndrome is necdin, Necdin. Okay, and this is there are studies on necdin knockout mice. So they took away, or they made the necdin stop working in mice with PWS, and they engaged in excessive grooming behavior. So they needed a lot more force to soothe themselves. Even a mouse in a laboratory setting needed an excessive amount of grooming to feel soothed, right? So there is a component there, these dual aspects, a habitual aspect, right, which is leading to that compulsivity, and then there's this aspect of requiring an excessive amount of force or even tissue damage in order to get that self-soothing. So I don't have a very easy answer for that. I do know that there are several medicines that help with that, right? So the medicines like Guanfacine, right? In my study, I'll show you some slides on that, has shown to reduce skin picking. Topiramate is another one which has shown to reduce skin picking. And N-acetylcysteine is another one that has been shown to reduce skin picking. There's some evidence for SSRIs like Sertraline also, but you have to use that with more caution. If there's no excessive daytime sleepiness, then my go-to is always Guanfacine, because it sort of bypasses the other things, doesn't cause an increase in dopamine or serotonin, doesn't mess with those things. There's another question. There are two questions, yeah. Yes. Yeah. With modafinil? Oh, Petolescent, yes. So Petolescent is being studied for excessive daytime sleepiness, right? The off-target effects, so the other effects are not known yet. We are still waiting to find the results. But it is a non-stimulant type of medicine that helps with excessive daytime sleepiness. Modafinil is also a non-stimulant type medicine that helps with that. There might be some evidence to help with ADHD symptoms also. Not as much as stimulants, though. So I know I have only 15 minutes left, so I'll try to zoom through some more. Okay, so sir, this is what we were talking about earlier. For picking, usually the first go-to is NAC, and N-acetylcysteine. This is actually lower than what I go. This was in my book, so I didn't want to get sued by anyone. But you can go much higher than this, okay? And that's N-acetylcysteine is over the counter, and people are very wedded to something called Pharmanac, which has to be imported from Canada. I don't go nuts over that stuff. You can get whatever's in the pharmacy next door, NAC, but it should be only NAC, not other things. No, not at all. It's over the counter. I it I haven't seen that always, right? There are some patients who respond well and then they stop responding, but oh, okay, okay. That's, I mean, it's, I don't have like an end-to-end comparison, but I've had patients with Pharmanac who say it's not working also. So I think NAC is over-the-counter NAC, or for any reputable brand should be okay. But if there isn't enough response, these are the three options. So Guanfacine or Intuitive, topiramate, and naltrexone. Topiramate is Topamax, and then naltrexone. So naltrexone is also, both topiramate and naltrexone also help with weight loss. Okay, so that's, and topiramate has separately been studied for hyperphagia. I don't think we use it as often as perhaps we can. The only issue with topiramate is that if you have a very if you have a very high functioning loved one with PWS, and you feel like any deterioration in their executive functioning or ability to sort of just, it kind of like, so jokingly, Topamax is the brand name, and we call it Dopamax. So it's not like it kind of it's not like it lowers your IQ or kind of makes you sleepy, but it kind of slows you down just a tiny tad. And most patients, they don't notice any difference, but some patients who are, like if you're, for example, if you were a lawyer, or you are sort of like a high-speed train, sort of operator, then you should probably not take Topamax. Okay. All right. Lamotrigine. So Lamotrigine is a mood stabilizer. So that would go in that previous. Uh, this is where it stands. Lamotrigine hasn't been shown to reduce skin picking, but it is a mood stabilizer. So I do have a couple of patients on it, which help. It helps. It's the effect size, or the number of people that you'll need to treat with lamotrigine to get the same effect as, say, risperidone would be higher. So I would choose, but lamotrigine does not cause any weight gain. So if weight is a huge issue and I have a lot of time to titrate the dosage or go up slowly, then lamotrigine is a good option. Okay, so we went over picking. Okay, now psychosis. Now this is not schizophrenia, and there was a question about, what's the difference between schizophrenia and psychosis and PWS. There's a sudden alarming change of behavior. So this is not something that you would, that you will know when this happens, right? There are a lot of, remember I was talking about chronic versus episodic change. There are lots of things that change all of a sudden overnight usually, right? There's sleep disturbance. So usually our patients, our loved ones are sleepy, right? But all of a sudden they have trouble falling asleep, right? They're staying up all night, they're pacing, they have catatonic symptoms. So that's when they get stuck in positions and postures. So, and people get confused because, they associate narcolepsy and catalepsy, right? Where there's loss of, muscle tone, and there might be some movement abnormalities in narcolepsy as well. But this is different. There is reduced sleep with catatonic, getting stuck in weird positions. So there'll be, if you give your child like a glass of water, they'll be just stuck here. And then sometimes you try to move them and they resist movement. And that's catatonia. Um, there might be confusion, they might appear confused, almost delirious, right? They may not recognize you, they may not know where they are. They may have voice hearing experience. Now that's where a professional comes in the picture, because it's very hard for you to ask the right questions. But if you ask something like, "Are you hearing something that no one else can hear?" Or you see them kind of cocking their head to one end and kind of speaking to themselves or laughing to themselves. And that is voice hearing experience. And there's paranoia. They're going to say, "Oh, Dr. Singh gave me that medicine 3 years ago, and I know Dr. Singh, there was a chip in that medicine, and now he's controlling me." It's not true if you hear that. All right. But there's a lot of hope. They respond very well to treatment, very rapidly and very well to treatment.
The difference between hallucinogen or hallucinating and delusion.
Okay, very good. So hallucinations are perceptual abnormalities. So I'm seeing or hearing or in touch or in taste or in smell, experiencing in the world something that no one else can. That does not exist, right? So if like from an angle in the dark, if I think that there's someone sitting on the chair, right? And then the lights get turned on and there's no one there, that was an illusion, right? Whereas lights are on, everything is here, and I think that, like Clint Eastwood, there's someone sitting on the chair, then, oh, no one got that reference. Okay, so, and I'm talking to someone imaginary on the chair, then that's a hallucination. I can actually see someone no one else can see. Visual and olfactory, like smell, type of hallucinations are very alarming, should not happen. If your child is saying that I'm seeing things, or I have a weird rubber type smell or taste, then that's something else. Then you have to rush them to your doctor to explore that. Auditory hallucinations are the ones that are pretty common, and they get treated with the antipsychotic type of medicines. That's where they're hearing something that you can't hear. That's a hallucination. A delusion is belief. It's not perception, it's belief in something that is not possible, right? Or that is not real. And so it's a little different from the very common ideations that our patients with PWS will very commonly, they'll have this infatuation for a caregiver or something like that. "Oh, I love them," or "They love me," and "You don't know, they're my boyfriend," and on and on and on. And that's very common. I wouldn't call that a delusion. On the other hand, they say, "Oh no, that person, you don't know, they have been controlling me," or they have told me to go hurt someone. Those kinds of things which are more bizarre, that's definitely a delusion. Yeah. Buspirone, okay. Zyprexa. So Zyprexa is olanzapine. That was one of the medicines that I mentioned earlier. It's very effective, but can cause a lot of weight gain. Okay, the buspirone has very little to no evidence in Prader-Willi syndrome. Not that I'm aware of, right? Yeah, yeah. So it's not the most effective medicine, but it also has very few side effects. So just people tend to come in on it, and then even if you stop it, I don't notice a huge difference. But definitely, talk to your doctor before stopping it on your own. But it's not a very highly effective medicine. Cannabis. Okay, so cannabis is a tough one to go through, but if so, this is a good slide to kind of be on for cannabis, because cannabis. The problem with cannabis is that it can lead to psychosis. So people are very liberal with cannabis because it's just the cool thing to do nowadays. But The plant itself has many chemicals in it, right? But there are two kind of opposing chemicals. It's called an entourage effect, right? So which means that the THC is the stuff that is psychoactive. You smoke it, you get high, you start hallucinating, you have perceptual changes, and it can cause psychosis. Young black men in particular, they seem to have a different type of gene, a COMT gene, yeah, which and that in particular they are at higher risk of developing psychosis at a young age if they are exposed to cannabis and to heavy users of cannabis. That's not something that's talked about. I don't know why. They're well studied, right? And a lot of at least 4% of the population will develop psychosis that will be sustained even after stopping cannabis use. No one talks about it. I don't know why. But the part of the cannabis that is problematic is THC, right? The part which is supposed to be supposedly safer, and there are products that are coming out, and it has like an opposite antipsychotic, anti-anxiety, and perhaps even appetite lowering effect is CBD, right? Not there are some studies on it in PWS, and they're positive. If I were you, I would wait to see which, the purity of stuff, and what component, and I think the dosage. We don't know that well enough to. I don't prescribe it at all because I'm not very comfortable with it. I don't know. I don't know enough about it. Yeah, correct. Yes, there are studies happening. There are studies. Yeah, there you go. There are so many types. Exactly. So I think that we need to come up with a synthetic compound which does what CBD does, and then study it and then see what happens. So, I know we are at time. So the yeah. So again, if there is psychosis, we have to use an antipsychotic. Okay. All right. So Guanfacine, we spoke a little bit about it. It's already ADHD approved, FDA approved for ADHD. That's why I was able to study it without having to go through this billion-dollar process, right? And that's why I want you to know that all we heard in the FDA trial there are lots of barriers, but please be open-minded to things that are already present, right? They're just not being marketed for PWS, but they're FDA approved, and we should take advantage of them. So I've had, so this is like fresh off the press, I'm more than halfway through my study with Guanfacine, and the response has been really heartening, right? So we took patients, and the reason for treating with Guanfacine was not hyperphagia. It was aggression, irritability, skin picking, things like that. And we gave them placebo or Guanfacine, right? In the placebo arm, right, there were 6 people who were exposed to placebo, right? And 5 of them did not respond. One did have a response. So placebo response is there. With Guanfacine, it was really the opposite. 4 of them responded. Only one did not respond. And I can tell you that that one person actually turned out to have psychosis. I had to treat them with risperidone down the line. And then, these patients, the placebo arm, we gave them open label, and pretty much all of them except one went on to respond to the Guanfacine. And as you can see, these are all significant. So p-values are low, which means that that's what FDA looks at, right? So self-injury trauma scale, mean score. So the severity of skin picking went down, And so severity and numbers. So the number of wounds went down, the severity of the skin picking went down. That includes rectal picking also, by the way. Then aberrant behavior checklist, which means that things like impulsivity, aggression, and also things like sociability, and also expressive language, these things improved, and so did overt aggression. So this is just some more slides. I'm also excited about what FPWR is coming up with. We're honored to have Dr. Tony Holland in the room, who actually did the initial studies on vagal nerve stimulation. So we're doing a study on vagal nerve stimulation. I think there's only one um, in-person visit for this. So just last thing, I know we are at time. The Guanfacine, I was excited about the Guanfacine because it reduces the sympathetic tone, the fight or fright and freeze response in the brain directly. And what vagal nerve stimulation does is that it does the same thing by reducing the fight, fright, and freeze response peripherally on the vagus nerve, so from the outside. So you remember that diagram, there's inputs from the outside and inputs from the inside, and our kids and loved ones have trouble sort of like making the right decision based on that information. So it lowers the threat level from the outside. So it's like deep breathing, except you don't have to train them to do that. Um, so that's it. I'm gonna stop now. I've been asked to stop like 5 minutes ago, right? Yeah. So do we have time for like questions? Okay, 2 minutes. Okay.
A lot of things that you mentioned I'm going through right now with her experiencing psychosis, and she experienced anxiety towards the end of the night, mainly because she's thinking about food, I think, around that time when she's not most busy. So at that time, she's on currently benzotropine, she's on Neurontin, and she's on one other medication, but none seems to work and helps her at all with sleep. So I'm up sometimes to like 5 o'clock in the morning and not able to get sleep because she's just fighting through the medication. And so nothing really seems to help. She's tried multiple things, and I just want to know, like, what are your suggestions for that? Yeah.
Okay, so the question was, people are very aware of the sleepiness in PWS, but they're not very aware of the insomnia that can also happen in PWS. By the way, I know people are leaving, but I just want you to maybe take a snapshot of this. These are some of the studies that we're doing right now, and that's my book if you guys get a chance. Now, you can get the book on Amazon. You can just put my name in or put the name of the book in and you'll find it. So the question was about how to help people with PWS sleep. Now, you mentioned psychosis. So if there is active psychosis and that is causing the insomnia, then you have to treat the psychosis. And the antipsychotic medications are sedating. So that takes if they're not sleeping, then the likelihood of their psychosis going away is very low. So they need to sleep. Now, you can have sleep problems independent of psychosis, which perhaps that's what's happening. And in that case, very prudently, I didn't mention benzodiazepines, medicines like Klonopin or Ativan, things like that. I didn't mention that here because there are risks involved. However, in that extreme situation where people are not sleeping at all, there is a role for benzodiazepines. I usually prefer long-acting benzodiazepines like clonazepam, which are which will not only help them fall asleep but also keep them asleep. Now, there are people who have just problems initiating sleep or just falling asleep, but they're okay once they fall asleep. In that case, melatonin is pretty good. But if that doesn't help, then a Z drug like zolpidem, which is like Ambien, can be helpful. So another question. Okay. Right.
I'm sorry.
Okay. So thank you all. Thank you for coming.